Hi, I'm Laura Sifferbean. I'm Desanio's Medical Outreach Director, and I'm so happy to have everybody here today. Just a little disclaimer to start that by watching the webinar or asking questions or interacting with any Desanio staff or volunteers or our website, it does not constitute a doctor-patient relationship or legal or medical advice. For that, you should ask your person's own physician or lawyer. But moving on from that, I'm just going to ask everybody to mute, and there will be time for questions, but we're going to hold that till the end. So I'm so happy to introduce Dr. Ievers-Landis and Dr. Ibrahim here from University Hospitals, Rainbow Babies and Children's Hospital, to talk to us about Down syndrome and sleep behaviors. So thank you so much for coming, and I'll turn it over to you.
Hi, everybody. Thank you for joining us. I'm Carolyn Ievers-Landis. I'm a licensed clinical psychologist. I'll move to the next slide here. So, whoops, I have to click on it. I'm a licensed clinical psychologist, and I have my diplomate in behavioral sleep medicine. So I see children and adolescents and young adults clinically at Rainbow. And I also am a professor of pediatrics, so I do research, and I'm an editor of 2 pediatric journals, an associate editor. And then my co-presenter is Dr. Sally Ibrahim, and I will let her introduce herself.
Hello, everyone. Sally Ibrahim, I'm one of the sleep medicine physicians here at Rainbow Babies and Children's. I've been practicing maybe, I think, 15 years. Somebody was asking me recently. Wonderfully working as a team with Drs. Ievers-Landis on many of our patients have both behavioral and medical conditions. And so it really made sense for us to sort of co-join, as we do many times for many talks, as we join to treat patients as well. So thank you for coming, and hope we can provide some information tonight.
Yes, and I also, as Dr. Ibrahim and I were talking earlier, that I also see patients with genetic conditions. And so I do see adults in that regard. I oftentimes will see adults with Prader-Willi syndrome, for example. So I have had experience treating sleep problems with adults as well. So we wanted to talk about sleep and give a primer as to what we think is most important. And what's really most important about sleep: duration, regularity, and timing is really what's important. And I wanted to think about this from the whole age range, from infants all the way up through adults. So what we care about is total hours of sleep per day, which includes naps. And I'm going to talk about this a little bit, but I really find that looking at the opportunity for sleep compared to the need for sleep is very important. And I do find this for some of my patients with Down syndrome, is that they might be in bed for a little bit longer than biologically would make sense for them to be in bed. And sometimes that's something I need to talk with families about. Regularity means the differences in bedtimes and wake times. I particularly focus on wake times, and mostly we see kids sleeping in on weekends. So regularity of sleep is very important. And you could even say it's more important than duration, but it's at least as important as duration. Timing of sleep is important too, and that means when sleep is happening. So that's if you're sleeping early or late, and not just when it's happening, it's how does it fit with your circadian rhythm or your child's circadian rhythm. So I find that most people, including parents, and also possibly including some medical providers, might focus more on sleep duration. So really, I want people to think about duration, regularity, and timing. So sufficient sleep is necessary for optimal sleep health, and I think I just talked about this. I also want to talk about the genetic need for sleep. It really is sleep. The need for sleep is a bell curve, just like everything else. Some children need more sleep. Some children need less sleep. Some adults need more sleep. Some adults need less sleep. And I oftentimes will ask my parents, are you a shorter sleeper? Are you somebody that can kind of get by in 6 hours? Or are you one of those people that you need your full 8 hours to function? And then talk about how that might relate to their child. I want you to know that National Foundation or Academy sleep duration guidelines are, based upon the literature. They're based upon these expert panels, but they are guidelines. And oftentimes they're looking at what is the average. And oftentimes it's based upon what parents report their child is sleeping, not necessarily from actigraphy. And we know that parent report is longer than actigraphy data or like a sleep kind of tracker data. In fact, I was just looking it up for Down syndrome and found that for parent report, it was 2 hours longer than the objective measures of sleep. So you have to take that into account when you're thinking about the guidelines and how that applies to your child. So again, if it's unclear, come to us or another sleep specialist and figure that out. So here's a graph that I like to share based upon this Chaput article that came out in 2018. This is an article that looked at sleep parameters across the whole world. And it looked at actigraphy and it looked at parent report. And it was actually lower than some of the other guidelines that we've seen. So looking at infant and toddlers, like look at that huge range from 9 to 13 hours with an average of almost 13. Preschoolers sleeping on average closer to 12. School-age kids closer to 9. I think most people, when they think of school-aged kids, they think they should be sleeping 10, but it's really 7.5 to almost 11 is the range. It's pretty large. And then when we're talking about the younger teenager, as actigraphy was showing that 8 is average, and this doesn't necessarily mean what we recommend. This is more based upon population norms. And then for the older teenagers, they're sleeping around 7.5. And again, that's not necessarily what we would recommend, but this is population norms based upon studies across the whole world. So I think this is interesting to think about. Oh, you're.
I'm sorry, I was muted.
Oh, no problem.
And so in the moving on to adults now, sleep duration does change and then stabilize. And so when we get from, the developmental stages and into, and adolescence goes sometimes up to 21. So it's an interesting concept for some people. So and then you wiggle into the adult world and we start to see norms between that 6 to 9 hours, with that sweet spot being 7. And just like Dr. Ievers-Landis said, there's this nice little bell curve, and then we have the sweet spot. If you sleep just right in that sweet spot, you don't get the bad stuff. You don't get the diabetes and the stroke and the heart disease. These are all population studies. So people report in what they sleep, and then they figure out, well, this population that sleeps less than this many hours gets more, and especially less than 6 hours. But we start to see some problems less than 7. We also see some problems, ironically, kind of with more sleep. But there's a literature that thinks maybe those people may be a little bit more sleepy for other reasons, and maybe that's why they're having some problems. Let's say, for example, obstructive sleep apnea can make you sometimes sleep a little bit more. So, but if we're talking just sleep duration and we have good quality sleep, that sweet spot for adults seems to be 7 hours. More than less than that, we see weight gain and obesity, type 2 diabetes as listed here, and some other problems. We can go to the next slide.
Sorry, I was having trouble seeing my cursor. So I was looking at, what the research literature says. So for sleep duration in children and adolescents with Down syndrome. So looking at this study that came out pretty recently last year, that and it really are large age range, they were found to have the same duration of sleep as typically developing children. And here's another study with a smaller age range with older kids, 10 to 17-year-olds, where they were looking at lots of kids with chronic conditions compared to kids without chronic conditions. And the sample of kids with Down syndrome, or teenagers, I should say, older children and adolescents, was 51. And they were looking at, multiple health behaviors, but one of them was sleep. And they were looking at who was sleeping 9+ per hours if they were less than 13, or 8+ per hours if they were the older teenagers in the study. And if you look at this, and these are lots of different conditions of childhood, I found it fascinating that when you look under the first column and you look at Down syndrome, which is like about halfway down, they actually had the highest percentage of children meeting the individual behavior guidelines for sleep compared to all the other groups. So that was really fascinating to me. And that's my little, I don't know if you can see my little person that my son drew representing me. So that's neat, pointing out that these kids really had more sleep. So that's kind of interesting as to why in this study kids with Down syndrome tend to be getting more sleep. So in terms of that, so we're happy to see that the duration seems to be at least the same, if not better, than kids without chronic conditions of childhood. So I wanted to move on to sleep regularity, which I love this concept, and I do research, and I am very interested in this concept. And, when I think back to when I was a child, I think my mom thought there was such a thing as make-up sleep. If I slept till 1 or 2 on the weekend, she thought that was fine. But there really is no such thing as make-up sleep. And we know now that irregular wake-up times between the weekdays and the weekend days can really cause this term called social jet lag. So if we spring forward, even a 1-hour change affects us as a society. It was so interesting after the recent change of time. I was listening to the radio when I was driving to work, even though the change went a way that you would think people would be better in the morning. There were a lot of car accidents, I noticed, on the day after the time change happened. And that's actually, they find that there are more issues with that in terms of driving and other things when the time changes, and that's even 1 hour. Some adolescents and even some adults are sleeping 5 to 7 hours later on the weekends, and we always kind of think of it as traveling somewhere, like, it's 3 hours you're traveling to California, it's 5-6 hours you're traveling to Hawaii, or even beyond some of the Polynesian islands. So we talk about, try for a weekend wake-up tip, Dr. Ibrahim can talk about this, that is only 1 to 2 hours later than the weekday wake-up time is what we recommend. And people ask us that often. So here's another sleep regularity from one of the same Horn et al. Paper that I was using to show that children with Down syndrome have been found to have less variability in bedtimes and wake times compared to typically developing controls. So that was interesting too. But social jet lag can cause us, if everybody's been in a different time zone, you feel groggy during the day, you're lacking energy, you might have difficulty concentrating, and then people might have difficulty falling asleep during the week. Okay, and Dr. Ibrahim will talk about sleep timing.
When we go to sleep, yes, it's a big topic. And, when we were in COVID, everybody went to sleep a little later. That was what the data showed. And then when we got back into, starting at 8 and needing to transport to work and transport back to school, we saw people's timing change. It's interesting how our society, sort of shifts based on these kind of larger things that happen. And the same concept for daylight savings time. So Dr. Ievers-Landis said, when we go to shift, and we're currently now in daylight savings times, we lose that hour, and then it's darker in the morning. And so it turns out that kids have a harder time waking up for school, especially high school kids. So do some adults, especially those who have to commute before 8 o'clock because they're not getting that sunlight. And it turns out when we sleep is mostly related to when we see light, and when we wake up, we need to see light to be able to wake up and have sort of what we call circadian rhythm, right? That 24-hour cycle, all our clocks in our body are adjusted based on that. So it's interesting how and you'll start to notice this, we're going to have less light in the morning and it'll be light at night. And some people like that, but at the detriment of no light in the morning. And it turns out all the studies say no light in the morning is actually bad for us long term. So you'll see this. There's national things happening on a national level. All the sleep experts are supporting standard time, which was where we were before and before the time change, and making that permanent. So we don't have to have the car accidents Monday morning and through the week because of the social jet lag and the time change. So crossing fingers, this will be a thing of the past, and hopefully we'll have a more permanent time going forward.
So thank you for talking about that. So now we're going to be talking about sleep timing. It's really optimal to have a schedule that fits with your natural circadian rhythm, which we call synchrony. And when it's out of schedule, we call it dysynchrony. And it's really difficult for children, mostly older children, adolescents, because of early school start times. But we have those little ones. I even see 4-year-olds that are little night owls already. They seem to be little teenagers already. There's a sleep disorder called circadian rhythm disorder, delayed sleep phase type. And this is really a sleep clock problem, and it's more common in adolescents. And because I wasn't certain if there might be some adults on this call with Down syndrome, I just wanted to let you know that it can also affect adults. And interestingly, it's more common among women between the ages of 40 and 60. So if you might think you might have a circadian rhythm disorder, it can also masquerade as insomnia. And some people have both. There are behavioral treatments available to treat this sleep disorder. We can talk about some of those, later on if people are having, problems with that. But things like light exposure in the morning, timing of meal times, making sure you're getting physical activity. There might be something about melatonin use or other things, and making sure that you're having regular sleep on the weekend. So those are things that I work on a lot with my patients. And go ahead.
And this idea of synchrony is so critical for all the health functions. Turns out we have clocks all over our bodies. And so when we have to take our diabetes medication, when we have to exercise, when we have to go to doctor's appointments, and if we can't wake up for those processes, or we take our medications at different times because we're not in sync, we can really wreak havoc on our health. And so in general, people do better when they're very synchronous. We don't have to be military style up and out of bed every day, but we want to get pretty close. And like Dr. Ievers-Landis said, that shift between 1 to 2 hours on the weekends, if we have, or holidays or off days or some off, school days, then we just want to be able to kind of stay within that range, and we tend to be healthier. Once we get out of that, and we have a very difficult time going to sleep and a very, very difficult time waking up. This could be that circadian rhythm disorder that's outlined in this slide. And so the normal circadian melatonin curve is in the black. If we were to be going to sleep, our natural melatonin kind of has a peak effect and then back down. And so once we're awake, it's off and we feel good. And then in the morning, we're fine. The person who has a delayed phase can't fall asleep. Their melatonin is still not ready to go up. And so they're feeling very alert. And you may have that sleep onset insomnia. Then they have very difficult time waking up. And so that's the trick is to, if you really want to know, does my child have this? Do I have this? Does somebody have this? It's really trouble falling asleep and then trouble waking up at the right time. It's all about time. And so that morning sleepiness, difficulty waking up from sleep, kind of dragging them out of bed to try to get to school or get to work or do something, that could be all circadian. And another thing is that unfortunately this can cause insufficient sleep. And then they can shift right to the weekend or the off days where they can get sufficient sleep, but that's sort of falsely sufficient, because 5 days a week, let's say for school, they're getting insufficient sleep. And then 2 days, they have some more sleep, but it's not enough. That's why makeup sleep isn't really makeup sleep. You can't make up for those lost days. So the best thing we can do is regularize these schedules as much as possible within 1 to 2 hours.
I think that's perfect. And what we think about is like a typical sleep cycle, which is around 90 to 110 minutes. I believe that it's okay to shift maybe one sleep cycle, but you really don't want to shift more than that. That's kind of what I try to talk to my patients about. So, what can be done during the day to promote better sleep? Because I always tell people, oh, sorry, this was your slide, but I always tell people they have to earn their sleep. You actually have to do something. I think we all found this out during COVID. If you lay around and do nothing, it's kind of hard to sleep well at night. But what are all the things we do during the day that promote better sleep? Okay, this is your slide.
Right. And so the promoting things are going to be in green going forward and red impeding. And so I love this, the way Dr. Ievers-Landis did this. So it's important to know, what is it? What promotes it? So what do we have to do? Well, we have to wait. We have to be awake all day long. At least in our society, there are some societies that do siestas. We're not one of them. We're not privileged enough in the United States to do this mid-afternoon siesta. So if we had a siesta, it would take away the drive to fall asleep at night. And so it's sort of like eating the meals at the wrong time. You're not going to be hungry later. So we have to be able to earn our sleep by staying awake, if I can use that analogy, kind of earn the sleep. And that increases adenosine. It kind of goes up, 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 up. And then when we fall asleep, we have this stronger drive to fall asleep. If we take caffeine, it takes away from the adenosine. It blocks the adenosine. And that's why it can sort of help us wake up. But we'll talk about caffeine. The other thing that puts us to sleep, of course, is what we talked about before, the timing of sleep. So when we woke up for those last 5 days, we can't expect our bodies to then fall asleep earlier suddenly the next day on a dime. We have to turn our clock to be in sync with then our drive to fall asleep. So these two components are critical to fall asleep. And then sunlight, so our world is sort of dark and light, and our dark and light cycles kind of shift with, melatonin is in the dark cycle. Sunlight is when we wake up typically, with the exception of people who do shift work. And so some people are very light sensitive and others are not. There are some artificial lights that can also help us if we don't get enough sunlight, like in Cleveland, for example, in the winter months. Sometimes we can replace sort of natural sunlight with these other light, but light is a powerful thing. And it turns out if we can get outside and get really good sunlight, we have a more robust melatonin at nighttime. And so it also just helps us sleep better, it turns out, probably because of some of these physiological things that happen. It affects both the ability to fall asleep later and also the circadian rhythm. And then, of course, sunlight also helps us get our vitamin D, but wear sunscreen, of course. Insufficient and deficient levels really of sunlight are linked, unfortunately, especially with vitamin D, with shorter sleep duration, less efficient sleep, and then more tiredness during the day. And so because we live in Northeast Ohio, we have to make a stink about vitamin D. If you don't take vitamin D, you're probably insufficient. Most of the studies, some doctors don't even check vitamin D. They say just take it, because everybody in Cleveland seems to be low. And so we need just a little bit more than the recommendations, unless we're living near the equator, which we're not. So taking vitamin D can help a lot of processes, including sleep.
So that's a physical activity is also very important. And we're talking at least moderate to vigorous. Sometimes when I talk to some of my teenagers, they're so cute when I ask them, what do you do for physical activity? And they tell me, I walk around the house. And I just think that's really cute. And I'm like, okay, that's good. But we need to get your heart rate up, because moderate to vigorous sleep really promotes quicker sleep onset, more efficient sleep, and being able to sleep longer. So regular physical activity also affects the SNC drives of that two process model. So it's really, really important. And I do this a lot, so much with my adults that have genetic conditions, to plan daily physical activity, like being in organized or rec league sports, taking classes like at the gym, or where you live, doing classes, Zumba, karate, whatever you like. I know Richard Simmons is very popular still with some of my patients. Scheduled activities with family members or friends so that you're more likely to go and do that. So it really is important to do the physical activity plus the sunlight. So I really like it when people exercise outside. That's really great. Earlier bedtimes and wake times, shorter time to fall asleep, better sleep quality, and as Dr. Ibrahim was talking, higher melatonin concentrations. So I was looking at this is the same graph or table we were looking at earlier. If you look at the second column, that's physical activity. And then if you look halfway down where you see Down syndrome, it's 15.7% of the children in the sample met the criteria for getting enough physical activity. And that's compared to children without a chronic condition, which were getting 21%. So of that list, where some of them were lower, some of them were 12, they were still on the lower side. So I think it's important to think about children and possibly even adults with Down syndrome and making sure that everybody is getting enough physical activity.
And hand in hand with physical activity is healthy nutrition and a balanced diet. And so there's not a lot of studies, diet studies, but what we know about what we're putting in our bodies is that when we have the whole grain, high fiber diet with lots of vegetables and, the food pyramid that we all grew up with, we do better. We also know that maybe a Mediterranean has a less inflammatory process, and we've seen people who are less fatigued in sleep clinics and across the nation when we do better in terms of a non-inflammatory diet. Of course, food allergies are interesting, and those can affect sleep in many, many different ways, especially sleep continuity, and make us tired the next day. And then, of course, caffeine, we know that blocks the adenosine receptor, that nice drive to fall asleep. And so we want to do things very judiciously with caffeine. And so some people really love chocolate milk at night. And so we say, sometimes if you're very sensitive to caffeine, we want to move chocolate milk away from the nighttime, or other things that could have caffeine in it. So they're putting caffeine in protein bars and a lot of things now. And so reading labels and ensuring that we don't do it past a certain time. Some people, again, are very caffeine sensitive, and some people will have caffeine and go to sleep. But we do know that we could still wreak havoc on the quality of sleep. So we try to stay away from the nighttime period, especially after 3-4 p.m.
And I think that's a really good point. And there are some studies with children that people are different. And some of my patients, especially some of my adolescents, will tell me they could drink caffeine and just go to sleep just fine. And that's okay. Everybody knows themselves. But we just wanted to make sure and bring this up.
And yeah, and the fact that everybody's different, because caffeine is so different in terms of how we metabolize it. It could quickly leave our system, but certainly keeping it to every person to kind of know what they do with caffeine. The other thing about caffeine is sometimes people with restless legs can have a worse restless legs with caffeine. So any stimulant, essentially, nicotine, caffeine, some of those other things can stimulate more restless legs. And that's probably why it makes us a little bit more restless when we sleep as well. So typically avoiding if we can. Yeah.
Okay, that's good to know. I didn't know that. So sleep promoters, the timing of meal times. It's really important to think about the timing of your meal time. So a lot of our kids, especially the teenager, don't like to have breakfast in the morning, but breakfast is a really important daytime wake behavior that triggers the circadian rhythm that now this is a time for me to be awake. So people that feel sluggish in the morning, even though they don't feel like eating breakfast, it might be a good idea to do that. Also regular lunch and dinner times. And the timing can really affect this. So I have patients that unfortunately at school, maybe they have a lunch period that's 10:30 or something, and then they're eating like a dinner at 4:30, but then they're going to bed at 7:30 and waking up at 4 for the day, like they're up, so you can really, I literally had a patient where I moved everything later and they were able to sleep till 6 just by doing that. It was incredible. So eating too late, a lot of us are busy, we might eat dinner late. Think about how that might be pushing your child's sleep later or your sleep later. And also very important to not eat any food or drink other than water in the sleep window. There's a phenomenon called night eating syndrome. And I've had patients that will eat multiple times in the middle of the night to try to go back to sleep. And that can be very hard to break that habit. Other things as bedtimes and bedtime routines, there's been a lot of research literature in this, especially for younger children. It's really important to have a predictable set of routines and cues, and really helping kids develop these independent sleep onset associations. So how can they self-soothe at bedtime? I do this with parents all the time. I see children as young as 6 months, so I work on this a lot. So really trying for the parent to avoid being part of their calming down routine over time. So kind of weaning the child from rubbing the back, cuddling. I mean, I've also seen this with patients maybe that have autism spectrum disorders, that are, young adults that still kind of want a parent to help them calm down, and kind of trying to get yourself extricated from that. Another thing is to avoid prolonged bedtime routine. Sometimes people will go upstairs and spend an hour or two kind of in a bedtime routine, and that's really taking away from your active time where you could be building up more adenosine and being able to fall asleep faster and have better sleep. So we really don't want people to have a really prolonged bedtime routine. And families ask me about electronics all the time, and I am an editor or associate editor on 2 journals. I see so much research in this area. It's not a slam dunk. Everything is different. For older children and adolescents, I really tell parents to discuss their thoughts and feelings and have them think about how electronics impact their sleep, whether or not it might help them calm down and be distracted. Maybe they could listen to a podcast, maybe they can listen to music, maybe they can read a book with a bitty book light, even though that seems really old-fashioned. And from some of the research, we found that playing video games and texting with friends are 2 of the activities that do tend to push sleep later. So we generally tell people, because of light exposure, because of other things, if you can avoid screen exposure for 1 hour before bedtime. And I was very interested. The same table, once again, looked at screen time. And if you look at the 3rd column and you look at Down syndrome, again, halfway down, and you kind of go across, children, and this was, I think, 10 to 17 in the sample with Down syndrome, had 16% met the guidelines for screen time, compared to 45% of children without. Oops, so I think I said it the wrong way. Whoops, in my little bubble there. They actually, fewer of them met the guidelines than children without chronic conditions. So I think that's important to pay attention to. Even though they were sleeping more, they had less physical activity and more screen time. So just also talking about relaxation, distraction at bedtime, considering whether talking about your child's day might upset your child, or maybe it's helpful. It doesn't mean that you can't do it. Maybe that's something it's really good for you and your child to do that. But really thinking about something for your child to do. And I always say, I love this. So don't say try to fall asleep. I think most parents and most of us will be like, go in there and try to fall asleep, right? And I always say, what are you going to do while you're waiting to fall asleep? Because sleep will come when you're ready for that. So with a younger child, they can play with their stuffed animals. For an older child, I talked about listening to a relaxing podcast, a book, maybe listening to some music. If we can avoid light if possible, that would be optimal.
That's great. And then in terms of pets, we got to put this in here, in some situations, most situations as we age, pets disrupt our sleep. That's what most of the studies will say. And some children, though, they feel a sense of security or safety. And very young children could be pushed off beds. And so the safety goes the other way. And so sort of balancing all these sort of risks. You see all these cute pictures of kids with, with pets online, and some of them I just cringe because there's infants, and you never want to do that. Infants should always just sleep alone. But, but if they're going to be nearby with a very young child, you want to at least know that they're safe. And then, the allergies related to pets. But for by and large, when we get older, it turns out that pets are not really great for our sleep if they are in the bed and bedroom, because they do a lot more disruption. But, in terms of anxiety and some other situations, pets can be actually promote sleep, because there's that, again, that sense of security that they're okay.
And I think just like use of electronics, it's the same sort of thing. And caffeine, that everybody's different. And maybe you have a child that does so much better when a pet is in there. But just to realize that studies are saying that they disrupt sleep, but that doesn't mean it doesn't work for you or your child.
Yeah. And so I think this might be a summary in terms of what common pitfalls are in sleep. And so lengthy bedtime routines, kind of doing the, oh, are you going to go to sleep? Are you not going to go to sleep? And kind of doing all this negotiation around sleep. We want to sort of avoid that, make it short and sweet. And later, to build that adenosine drive, going upstairs for some quiet time. What are you going to do while you wait for sleep? Like Dr. Ievers-Landis said, putting your child to bed too early is a common pitfall, sort of hoping to fall asleep. Maybe if I put them in earlier or give them their sleep medication earlier, they're going to fall asleep. And that's a very, very common pitfall that some people we can't shift the rhythm that night. We can't shift the clock. That the right time is needed. If anything, you want to go a little later to really increase that drive and then promote that sleep association with going to the bed and being able to go to sleep. Allowing children to sleep in, because they don't sleep that much, I'm going to let them sleep in. Well, we won't correct the rhythm then. We won't be able to do that 1 to 2 hours and keep things so regular, which is so healthy for us. If we take naps too long or too late, can hinder the nighttime sleep. And then the opportunity for sleep, kind of staying in bed for these very prolonged periods when they only sleep a little bit. And so we want to maximize sort of the efficiency of sleep when we are in bed. And then during the day, what are we doing? We're going outside, we're seeing sunlight, we're walking in nature, we're getting our physical exercise. Because if they're too sedentary, again, that's a common pitfall, and then we expect people to sleep at night, they're not going to do as well.
Perfect.
Mm-hmm. And we always have to have a melatonin slide in every sleep talk, because we're going to get a question about it. So we might as well talk about it. So it does two things. Melatonin is a very interesting thing, right? So melatonin is over the counter. I will say in Europe and other countries, it is regulated and it's a medication, not in the USA. And people have been talking about, well, maybe we should, FDA regulate. Well, it's kind of too late and it's out there. And it turns out in the US, we overuse melatonin. We use very high doses and we use a lot of it compared to any other country because it's so available. But what does it do? How does it promote sleep? Well, it helps our clock function, that circadian rhythm, and it acts like a hypnotic. So it can put us to sleep. And it also helps to get that clock a little earlier over time, along with the other things we do to shift a rhythm or shift the clock. So it's good for jet lag, social jet lag, and other types of jet lag. And then what are effective doses? So it turns out that, I used to, when I went to places with pharmacy, we used to see these very, very tiny doses, and we don't see those hardly anymore, those 0.125, which is still above what our natural body would make. And now we're seeing at least 1 milligram going all the way up to 10. And I've seen more sometimes, and then some people are taking more than that. So what's safe? Well, there's lots of studies that looked at things in children. 3, 6, 10, up to 5 and 10 milligrams have been studied with some, at least short-term potential safety. We don't know the safety beyond that. We don't really want to go above that. But this is a discussion, of course, with your physician, because melatonin can sometimes do some other things if combined with other medications and or other sedatives, I should say. So doses are increasing. Be aware of that. People are taking or giving too much melatonin to their children. It turns out in our country, gummies were studied recently. This is an interesting one. Yeah, it didn't even have melatonin in it, and some of them had CBD and some other things in it instead. So this is why people wanted FDA regulation. We're not going to get it. So right now we just have to trust the trusted brands. If it says melatonin on it, it's not always melatonin. There are certain brand names. You can ask the pharmacist or for a pharmaceutical grade melatonin. Those are more trustworthy, where the dosage is accurate and what's in it is accurate. And you never want to have a mixed product if you're going to use melatonin, because sometimes they're mixing in other things along with the melatonin. So you want to read those labels and talk to your doctor about the use of melatonin if you're considering it for your child or for yourself. And then I think lastly, this is potential sleep disorders. Even though we talk about behavior and what we can do, there are some things that can masquerade. And one of them is restless leg syndrome, especially in children. And so if children are very wiggly at night, or if they're getting out of bed, we might think they're not wanting to stay in bed for other reasons, but it could be a sensation that they're having that just doesn't allow them to fall asleep. And that could be restless leg syndrome. It's very familiar. There's a very strong genetic component to restless legs, but it can also be associated with things like iron deficiency. So younger children, there's a lot of overlap with growing pains or leg pains. And so a child who has any challenges with communication about what's going on with their body, they may say it's painful, even though it's not. And it could be both. It's usually both legs. And it's very hard to describe even for adults. And so children and people with special needs can have a very hard time describing it. So we always have a very high suspicion for restless legs if there's a sleep onset issue or even staying asleep issue. And another cousin of restless leg syndrome that we're kind of understanding a little bit more is called restless sleep disorder. General restlessness, kind of lots of tossing and turning and movements in sleep can really influence the quality of sleep and make people tired the next day. And then the next slide, I think, is other sleep disorders. And so other sleep disorders to consider being too sleepy. And so sometimes these sleepy disorders need to be evaluated further. So they're getting enough sleep, and yet they're still sleepy. So why is that? So they're getting age-appropriate amount of sleep and still so sleepy, or they're suddenly getting more sleep than they used to. The other opposite spectrum is, insomnia, not going to sleep, not staying asleep, maybe early awakening, and not napping or doing some other things. Parasomnia is doing things alongside of sleep. So sleepwalking, something else that's happening in sleep, nightmares can be included. And those things can also affect our ability to stay asleep. And then lastly, of course, snoring and breathing problems. There's a very high risk in people with Down syndrome. So we want to think about it. Snoring at least 3 times a week can really kind of make us a little suspicious for obstructive sleep apnea, which is a condition that not only causes sleepiness and next time day dysfunction, but in Down syndrome, it can cause extreme difficulty with cognitive functioning. There's mood problems, and they've seen things like, decreasing verbal IQ and some other things. So, and so it might also masquerade as staying asleep problem. It may be called insomnia because some children and adults with Down syndrome don't have your classic symptoms like snoring or breathing problems. These can be very silent in terms of their presentation, and so we have to have a high suspicion for obstructive sleep apnea in people with sleep in Down syndrome. And you can see here in this slide as to why we need that high suspicion. It's a very high prevalence, and so the prevalence in the pediatric population. At least half or more will have obstructive sleep apnea, similar findings in adults. And so there's going to be some data that's coming out with what we do in adulthood. There's a strong evidence for getting sleep studies by age 4 in children. And as we age, well, what else? What do we do? And there's going to be some guidance about what we are doing. We have to have a high vigilance for obstructive sleep apnea. And anyone who has a sleep problem or potentially a sleepy problem or high blood pressure or diabetes, because those are kind of things that might creep in as somebody has untreated obstructive sleep apnea.
I think all of these are so important because even though I'm a psychologist, I see even very young children with sleep problems, and we find out that they have, sleep apnea, or they have restless legs, or they have something else that's actually disrupting their sleep. And once we address that, their sleep is much improved. So I think these are all really important to think about. So that's the end of our presentation. We wanted to make sure we left plenty of time for questions. And I think we talked about possibly stopping the recording so that we could talk a little more freely.